I hope everybody's doing well and that the new year is off to a great start.
And good evening, everybody. My name is Michael Awad. I'm a minimally invasive surgeon at Washington University in St. Louis, and I serve as chair of the Resident Fellow Training Committee for SAGES. And as part of that role, I have the distinct honor of hosting these wonderful webinars that we put on every year for a review of general surgery topics in kind of a high yield question and answer format. We're so excited to welcome you all to this webinar, and we have a tremendous panel organized for you here this evening, and we'll let you know who they are here shortly. This webinar, just so you know, is a question and answer format, so we will make it interactive. We will have multiple choice questions come up on your screen. We will give a few seconds to kind of review the answers, and then we'll put up the response to the poll. You'll see a poll interface come up on your desktop or mobile phone, and please answer. We'll give about 20 seconds for the answers to come in, and then we'll go ahead and discuss the questions and answers, including the ones that are incorrect, in addition to the ones that are correct. There is a Q&A feature built into the Zoom, and so while we don't have the chat active, if you do have a question, please drop it in there, and we'll do our best to answer it real time or soon after you post the question. The webinar also will be recorded, and so in a few days it will be posted to the SAGES website, and you'll be able to review it at your leisure. So with that in mind, we'll go ahead and dive in. And I just want to confirm, Vieira, are we able to see these slides? Okay, great. All right, again, welcome everybody. This is our agenda for this evening, and this is Eastern time. We're going to kick off with Dr. Ivy Haskins, who will review surgical critical care and trauma, followed by Dr. Amy Rosenbluth, who will go over breast and endocrine, followed by Sarah Hennessy, who will go over pediatrics, transplant, thoracic, and plastics, and finally by Dr. Katarpal, who will go over vascular topics as well. So a very full agenda. Before we dive in, I just want to introduce you or reintroduce you to those that are familiar with SAGES. SAGES is the Society for American Gastrointestinal Endoscopic Surgeons, and it is the group that's hosting the webinar this evening. A really phenomenal organization that has really been my academic home for over 20 years now. And just a phenomenal group of individuals that are advancing the field of minimally invasive and endoscopic surgery, but also has been a huge supporter of resident fellow education and making these sessions possible. If you're not already, I would encourage you to be a member of SAGES. It's actually a really nominal fee to be a part of it as a trainee, and it actually rolls over into a full membership after you finish. And the vision and mission of SAGES, as you see here, but you can see education is a big part of this SAGES mission. And the values of SAGES are inclusivity, innovation, service, excellence, global community, and of course, fun. And as I mentioned, SAGES membership comes with some benefits, including a substantial discount to attend the annual meeting. All of these various courses and webinars and other things that we put on today is just a sample of what we offer. You get free access to surgical endoscopy, a high impact journal, and also several grants and career development opportunities. Again, as candidate or medical student members, you have the opportunity to join at a really nominal fee. And finally, I'd like to put in a plug for the next annual meeting, which is in Montreal this year. Really exciting, looking forward to that, at the end of March and beginning of April. So please save the date. I will be there and hope to see many of you in person. The SAGES General Surgery Review this evening is organized around the ABSITE content outline. This is what you can see here with all the topics that are covered in that examination, as well as the weights of the various categories. We already had part one back in December, another tremendously successful session, and that is already available online for you to review. And this is part 2, where we'll cover kind of the other bulk of the topics that you see here. Again, this will be multiple choice questions, and it will be a poll, an audience response system with answer rationales and discussion following the different questions. All right, so with that in mind, again, I'd like to introduce a great colleague and friend and a phenomenal surgical educator. Dr. Ivy Haskins is a member of the RAFT committee, and she is herself was a candidate member to the SAGES Board of Governors, which shows her amazing talent already from a very early stage in her career. Now she's a busy minimally invasive surgeon at the University of Nebraska. Dr. Haskins, good evening, and thank you so much for being here.
Thank you for having me, Mike. So the first question, a 36-year-old female is taken to the emergency department after being stabbed in the left mid-abdomen. She has minimal tenderness to palpation on examination without rebound or guarding. Her vital signs are within normal limits. A local wound exploration is performed in the emergency department and reveals that the anterior fascia is intact. The next best step is A, admission for 24-hour observation, B, discharge after 8 hours if serial abdominal examinations are unchanged, C, fast in the trauma bay, D, CT of the abdomen and pelvis, or E, discharge to home.
And we'll give just a few more seconds for folks to answer, and we'll have the results coming up on your screen here momentarily. All right.
Looks like it was pretty split. So the answer is actually E. So the important thing to know in this question is that the anterior fascia is intact. So if you do a local wound exploration, about a third of the time, stab wounds to the abdomen do not penetrate the abdominal cavity at all. A third of them penetrate the abdominal cavity but don't cause any injury, and then a third of them penetrate the abdominal cavity and cause injury. So if your anterior fascia is intact and a patient is otherwise hemodynamically stable, they do not need to be admitted for observation. If they have peritoneal signs or unstable vital signs, then they need to be taken to the OR emergently. And if on your local wound exploration, you find that the anterior fascia is not intact, you can proceed with a CT scan as long as they remain hemodynamically stable. Next question, which of the below trauma patients has the worst prognosis? GCS of 11, motor 5, verbal 4, eyes 2. GCS of 11, motor 4, verbal 4, eyes 3. GCS 11, motor 4, verbal 3, eyes 4. Or GCS 11, motor 2, verbal 5, E4.
And Dr. Haskins, there's a question in the Q&A from the last one about how do you, the challenges with assessing the anterior fascia at the bedside with digital exam.
Yep, great question, especially as our patients become significantly more overweight. So if you cannot reliably evaluate at the bedside, you either need to get a CT scan or take them to the operating room for better visualization.
Thank you.
So looks like most of you got the right answer for the second question. It was D, because the motor component is the most important or strongest prognostic component of your GCS score. So this patient in option D had the lowest motor score, so they would have the worst prognosis. Next question, a 21-year-old female has sustained multiple gunshot wounds to his chest and his abdomen. On arrival to the trauma bay, his systolic blood pressure is faintly palpable and his heart rate is 130. Massive transfusion protocol is activated. These protocols are associated with an increase in A, survival, B, blood products transfused, C, use of crystalloid, or D, coagulopathy.
All right.
Nice job. So the answer is actually A, survival. So in these protocols, the goal is obviously a balanced resuscitation. So you may have heard of 1-to-1-to-1 resuscitation, but this actually typically in this goal-directed resuscitation leads to a decrease in the amount of blood products transfused as well as the use of crystalloid, because you're typically giving blood earlier upon arrival to the trauma bay and upfront. So they typically need more blood on the back end. And these protocols are also associated with your other tenets to help prevent morbidity or mortality in these patients, including permissive hypotension, as well as preventing hypothermia and warming your patient in the trauma bay. The leading cause of death within the first 24 hours following a trauma is A, unbalanced resuscitation leading to coagulopathy, B, overwhelming sepsis, C, head injury, or D, bleeding. So the answer is C, head injury. So this is actually the most common cause of death within the first 24 hours, followed by bleeding. So it looks like most of you got the opposite. So just remember, your brain is precious, so there's not a lot of wiggle room. So patients who are presenting with a head injury need acute intervention. And bleeding, typically these patients can be resuscitated, especially with our newer massive transfusion protocols. A 76-year-old man is carrying groceries and trips and falls while going up the stairs into his home. He is on Xarelto for his anticoagulation and is found to have a subdermal hematoma. What is the best medicine to use to reverse his Xarelto? A, FFP, B, andexin alpha, C, PCC, or D, reversal agents should be chosen based on any TAG abnormalities.
Okay.
The answer is B. Unfortunately, this is one of those questions that you have to memorize. I think there's a nice picture. So just a quick review. So for Coumadin, the fastest way to reverse it is with your 4-factor PCC. You can also use vitamin K. If you give PCC, you want to also give vitamin K at the same time, just for the longer term effects. For heparin, it's protamine sulfate. For Pradaxa, it's Praxibine, which is the brand name. And then for your anti-10A anticoagulants, you want to give andexin alpha. The alternative would be 4-factor PCC, although that's an off-label use. So your andexin alpha is sort of like a decoy 10A molecule. So more of your anti-10A inhibitors will bind to this decoy molecule rather than your actual 10A receptors, and that helps reverse that agent. A 15-year-old female has been shot in the chest. He loses his pulse upon arrival to the trauma bay. You elect to perform resuscitative endovascular balloon occlusion of the aorta, also known as REBOA. How and where should the catheter be placed? A, through the right brachial artery into zone 1. B, through the right brachial artery into zone 3. C, through the right femoral artery into zone 2. Or D, through the right femoral artery into zone 1. Nice job. So the answer is D. So your Reboa catheter is always going to go through the groin, either the right or the left side, through your femoral artery. Remember that zone 2 is off limits. So if you place your Reboa and inflate it in zone 2, you risk ischemia to your small and large intestine. Zone 1 is equivalent to an ED thoracotomy, and zone 3 helps with control of hemorrhage from bleeding in the pelvis. A 28-year-old female is stabbed in the left upper quadrant in the mid-clavicular line. A CT scan of the abdomen and pelvis shows an elevated hemidiaphragm. Which of the following is the next best step in management? A, observation, B, exploratory laparotomy, C, diagnostic laparoscopy, or D, a fast exam. So your answer is C, a diagnostic laparoscopy. So the clues are that the stab wound is the mid-clavicular line, and on the CT scan, you have an elevated hemidiaphragm on that side. So there's a high risk or a high concern or suspicion for a diaphragm injury. In these patients, they need a diagnostic laparoscopy before being discharged from the hospital. If there are no other injuries, it's not an urgent procedure. It just needs to be done before leaving. Remember that your diaphragm injuries are repaired with permanent suture, often in a mattress form and sometimes with pledgets to offload the tension. Which of the following is true regarding the role of rib plating for the management of rib fractures? A, all patients with frail chest benefit from early rib plating. B, patients with frail chest often do not require rib stabilization. C, there is a benefit to rib plating patients with frail chest and an underlying pulmonary contusion. Or D, patients who undergo rib plating for their frail chest have an improved quality of life compared to patients who do not undergo rib plating.
And Dr. Haskins, there's a question in the Q&A about the place of diagnostic thoracoscopy for diaphragmatic trauma.
I don't think it's as accurate as a diagnostic laparoscopy, especially if you've already gotten a chest x-ray and it doesn't show a hematoma or other concerns in the chest. And so if you have a stab injury, you typically want to approach it from the abdomen. One, in terms of repairing, it's typically easier from the abdomen. And two, you want to make sure that other structures near the diaphragm are not injured, including your stomach, your spleen, and sometimes your colon sits up there too.
Thank you.
So the answer is B. Looks like we have some mixed answers here. So patients with frail chest often do not require rib stabilization. Unfortunately, there are no actual indications for rib plating to date. So we're coming up with new data. And of course, there are many institutions that are rib plating these patients early, but most patients who have frail chest actually end up doing okay without plating of their ribs, and no study to date has shown an improved quality of life over the long term with patients who have undergone rib plating versus those who have not. Which of the following patients would benefit from delayed burn wound excision? A, 20% total body surface area full thickness burn injury with inhalation injury as well. B, 20% total body surface area mixed depth burn. C, 20% total body surface area burn of indeterminate depth. Or D, 20% total body surface area partial thickness burn.
I need some discussion on this one.
Yeah, so your answer is C. So patients who have an indeterminate depth of their burn, you actually want to wait several days to allow that burn to demarcate into the specific degree before deciding if the patient needs an excision. So for example, if it's a 1st degree and a 2nd degree burn, you want to know how much of that burn is going to progress on to being a 2nd degree burn before you debride it. So your tenets for resuscitation still remain the same for these burn patients. It's just that they benefit more from delayed debridement just because you don't know how much you need to debride. So some of these patients, you can salvage some of their original skin and tissue. And final question for me, which of the following statements is not true regarding post-splenectomy vaccines following a trauma splenectomy? A, patients should receive their post-splenectomy vaccines prior to discharge from the hospital. B, patients will need to be revaccinated against H flu on a yearly basis. C, patients should be revaccinated for strep pneumo every 6 years. Or D, Neisseria meningitis is the most common cause of overwhelming post-splenectomy sepsis. Sorry, I think for B, it's actually patients will not need to be revaccinated. Sorry about the dog barking. So your answer is actually D. The most common cause of your overwhelming post-splenectomy sepsis is actually strep pneumo. Your H flu vaccine is a one-time vaccine. Sorry about the typo in that question. You don't ever need to check titers on these patients. And of course, when you're dealing with a trauma patient population, you're not sure how reliable most of them are. So you want to give these vaccines before they're discharged from the hospital.
All right. Dr. Haskins, thank you so much for that excellent review of trauma. Always a high yield topic every year on the ABSCITE exam. With that in mind, we'll go ahead and switch to our next panelist, Dr. Amy Rosenbluth. Dr. Rosenbluth is a expert laparoscopic general bariatric surgeon at Stony Brook in New York. And she is going to lead us in the discussion of another set of high yield topics in breast and endocrine surgery. Dr. Rosenbluth, thank you so much for being here as part of this panel again this year.
Happy to. All right, so a 43-year-old woman undergoes core needle biopsy after a mammogram revealed architectural distortion in her left breast. The pathology only reveals stromal fibrosis, so she undergoes an excisional breast biopsy. Pathologic examination shows ductectasia, squamous metaplasia, a 4-millimeter focus of lobular carcinoma in situ, or LCIS, extending to the inked margin. Her grandmother and aunt both developed breast cancer after the age of 50. What is the most appropriate management? A, bilateral prophylactic mastectomy and radiation therapy. B, high-risk screening with MRI and mammogram. C, right partial mastectomy and radiation therapy. D, re-excision to achieve clear margins. Or E, radiation therapy to the right breast. Good, looks like most of you got it. The right answer is B, high-risk screening with MRI and mammogram. So the point here to know is that she does have LCIS, which is high risk of breast cancer development in bilateral breasts, but not necessarily of lobular nature. That is not a pre-cancer in the same way that DCIS is. She does not need re-excision to negative margins because of this. She does not need radiation or a mastectomy or a prophylactic mastectomy, but because she's higher risk, she does need screening. A 73-year-old woman is found to have a left breast biopsy consistent with invasive ductal carcinoma, grade 1 ER/PR positive, HER2 negative. She undergoes a wire localized left breast partial mastectomy with left axillary sentinel lymph node biopsy. At the time of excision, a mass with a preoperative clip in the center of the specimen is seen on specimen radiograph. An unoriented specimen is submitted to pathology. On final pathology, one of the margins is positive for invasive cancer. 0 of 3 lymph nodes are reported. An Oncotype DX score is 9. What is the next step in management? A, because the patient has already had breast conserving surgery, mastectomy is her only option for a negative margin. B, a radiation boost to the tumor bed can be given at the time of whole breast radiation therapy to offset the finding of a positive margin. C, given the patient's age, low Oncotype score, and negative sentinel lymph node biopsy, the risk of local recurrence is low and a margin re-excision is not required. D, the patient requires further surgery to achieve a negative margin. Or E, the patient would require margin re-excision only if she had triple negative breast cancer because of the higher risk of recurrence with that tumor type.
That was certainly a mouthful question.
Need a glass of water now.
Yes, well done, well done.
Great. So again, the answer is D. Since almost all of you got it, I won't spend a ton of time on it, but the key here is it's a positive margin. You need to go back and get a negative margin. There's no other therapeutic alternative for that, whether that is going back and re-excising all margins of your tissue bed because it was unoriented, or a mastectomy if she wouldn't tolerate, cosmetically another excision. But the point is you need to get that negative margin. A 65-year-old woman undergoes a core needle biopsy for a suspicious right breast mass measuring 1.2 centimeters. The pathology is consistent with an ER/PR positive, HER2 negative invasive ductal carcinoma. The right axillary examination is negative for lymphadenopathy. She is planning to undergo breast conserving surgery. Which of the following statements applies to the management of her condition? A, axillary nodal evaluation is not necessary when cancers are less than 2 centimeters and the physical exam of the axilla is negative. B, an axillary ultrasound is required prior to breast conserving surgery. C, the patient requires systemic chemotherapy followed by adjuvant whole breast radiation therapy if breast conserving surgery is chosen. D, a sentinel lymph node biopsy is not necessary if the patient receives systemic chemotherapy. E, the woman requires a sentinel lymph node biopsy at the time of surgery and adjuvant whole breast radiation therapy.
Dr. Rosenbluth, I'm so glad you're going over these questions. I need this review.
It keeps me up to date on breast. All right, great job, guys. That's correct. The answer is E. So this is the Z11 trial. I'm sure you guys have all kind of had that beaten into you. Important to remember that for breast conserving therapy, you're going to need that sentinel lymph node biopsy as well as radiation. A 54-year-old woman completed her breast conserving therapy 8 months ago. She underwent partial mastectomy and sentinel node biopsy for a T1B-N0 invasive ductal carcinoma, grade 2, ER/PR positive, HER2 negative. She then received standard whole breast radiation. She's not had any imaging since her treatment began. On exam, she has some tenderness and increased density at her surgical site. What factors raise your suspicion that this is persistent disease rather than fat necrosis? A, the in-breast recurrence rate of breast cancer treated with partial mastectomy and radiation is high, at least 10% within the first year. B, she was treated with a boost of radiation. C, her surgical margins were positive. D, her mother and maternal aunt had breast cancer. Correct. The option is, or the correct answer is C, which almost all of you got. Again, surgical margins were positive. Just as a quick test taking tip on this question, whether you knew what was right or wrong, if something has a 10% risk of recurrence within the first year, it is probably not a reasonable surgical option. And so that answer could kind of be crossed off.
Good tip. Good tip.
A 72-year-old woman with a medical history of renal cell carcinoma 5 years ago presents to her primary care provider with complaints of unintentional weight loss, vague abdominal pain. A CT scan reveals a 4-centimeter heterogeneous adrenal tumor on her right hand. What is the most appropriate, right gland? What is the most appropriate next step? A, an FNA, B, a PET scan, C, urine catecholamines and metanephrines, D, a bone scan, or E, ultrasound-guided core needle biopsy.
I think that would be a case write-up to have an adrenal tumor on the right hand.
I know, right? I need to look into that. All right, option C, you guys are doing great on my section. Urine catecholamines and metanephrines. You never want to poke anything that might be a PHIO. So the FNA and the ultrasound core needle biopsy are a no-go until you get urine catecholamines and metanephrines. A 59-year-old woman undergoes an open left adrenalectomy for suspected adrenocortical carcinoma. Unfortunately, during the manipulation of the gland, tumor rupture and spillage within the abdomen occur. What is the recommended adjuvant therapy? A, mitotane monotherapy, B, surgical resection, C, chemotherapy alone for systemic control, D, radiotherapy for local control, E, radiofrequency ablation to the site of spillage.
Dr. Rosenbluth, we had a little operator error on this one where the answer was revealed a little prematurely, but
Oh no, I didn't even see that happen.
I know. Try to sneak it by, but we had some astute observers that I think caught it. But
well, I'm going to say that the 88% of you guys did not cheat, definitely knew the answer.
Good,
that's right.
Good.
It is mitotane monotherapy. And then again, just a couple of test taking things. Usually if something says something alone, it's probably not the answer. Things that are super, super descript, not always the case, but a lot of the times. And then again, if you think radiofrequency ablation to the site of spillage, if it's spillage within the abdomen, you're probably not radiofrequency ablating everything in the abdomen. A 69-year-old woman presents to the emergency department after a motor vehicle crash. CT of the abdomen reveals no acute traumatic injury. However, a left adrenal mass is noted incidentally. Which of the following CT findings is concerning for malignancy? A, rapid contrast washout on delayed imaging. B, evidence of high lipid content. C, measurement of 45 Hounsfield units, or D, a size of 2.5 centimeters. All right, little more debate on this one, but still most of you got this, the measurement of 45 Hounsfield units. So things that are concerning when you're looking at adrenal masses on CT scan is going to be adrenal lesions measuring more than 20 Hounsfield units, calcifications, a size greater than 4 centimeters, heterogeneous appearance. Things that measure less than 10 Hounsfield units are pretty reassuring. The lipid and the rapid washout is associated with adrenal adenomas. A 55-year-old man presents for further workup of GERD that has been refractory to PPI. A secretin test is performed. What change from the basal fasting gastrin level is indicative of a gastrinoma? A drop in gastrin level by 120 at 15 minutes. B, an increase in gastrin level by 120 at 10 minutes. C, a drop in gastrin level by 20 at 5 minutes. D, increase in gastrin level by 20 at 2 minutes. All right, again, you guys are doing great. B is correct. So remember the secretin test, you're looking for gastrinoma, ZE. So it involves getting baseline serum gastrin levels and repeating them after injection at 2, 5, and 10 minutes. And you just sort of have to know the number, unfortunately. A 37-year-old woman with a history of prolactinoma and prior subtotal parathyroidectomy for hyperparathyroidism presents to the ER with abdominal pain. A CT scan reveals a 2-centimeter pancreatic mass. Which of the following functional neuroendocrine pancreatic tumors is most likely? A gastrinoma, B, insulinoma, C, glucagonoma, and D, VIPoma. And for the question, yeah, it's 120 over baseline. Or I'm sorry, 120 increase from the baseline, I should say. Oh, didn't even see the answer pop up. Apologies, guys. Yes, gastrinoma is correct. So we are talking about MEN1, so pituitary pancreatic parathyroid. I'm not going to be so nice as to give away MEN2 to you guys, since the question's on MEN1. But the most common functional neuroendocrine tumors that you're seeing in this, gastrinoma 54%, insulinoma 18%, glucagonoma 3%, and VIPoma is 3%. So most likely it would be a gastrinoma. A 49-year-old woman is undergoing parathyroidectomy for suspected parathyroid adenoma. Intraoperative evaluation of the lesion reveals a 1.6 centimeter firm mass. Closer inspection reveals possible invasion into the ipsilateral thyroid gland. What is the correct next step for managing this patient? A, parathyroidectomy and ipsilateral thyroid lobectomy. B, parathyroidectomy and total thyroidectomy. C, complete the parathyroidectomy and wait for final pathology to decide adjuvant treatment options. D, parathyroidectomy, ipsilateral thyroid lobectomy, and ipsilateral neck dissection. Or E, parathyroidectomy with intraoperative parathyroid hormone evaluation to assess for complete resection. I think you gave me all the mouthful questions.
I know. You're doing great.
All right, so a little bit of debate on this one. The answer is parathyroidectomy and ipsilateral thyroid lobectomy. So when you're talking about a parathyroidectomy for parathyroid or concern for parathyroid carcinoma, then you want to do the en bloc resection. So you need to make sure that you're taking that ipsilateral thyroid lobe if you think that there's invasion. There's no reason to do a total if it's just invading a single lobe, and that's associated with increased morbidity because you're doing a total thyroidectomy. You wouldn't want to wait for final pathology because then you're going into a re-op neck. And again, the goal is en bloc resection. There's no need for a neck dissection if there is no obvious nodal involvement. A 55-year-old man presents to your office for consultation regarding suspected parathyroid carcinoma. His serum calcium is 14.7 and his parathyroid hormone is 314. Limited ultrasound shows a 1.5 centimeter loculated lesion in the right superior gland with a thick capsule. No further workup has been performed. What is the next best step in management? A, FNA of the lesion. B, core needle biopsy. C, en bloc resection of the lesion and surrounding structures. D, en bloc resection with ipsilateral neck dissection. E, follow-up ultrasound in 3 months to evaluate the lesion. I think the first question in that Q&A is biopsy for confirmation. So you would go ahead with the en bloc because the invasion of surrounding tissue is concerning for carcinoma. You wouldn't really see that with just an adenoma. And then what if parathyroid carcinoma is invading the recurrent laryngeal nerve? Do you resect the nerve? That's a good question. I'll give you that my assumption is you would, but I think we will probably need to discuss with an ENT surgeon for a little bit closer evaluation. But in general, the goal is en bloc. So if it is invading the nerve, that is part of your resection.
Indeed. All right, and their answer is up.
All right, and the answer correct, that's C. So en bloc resection of the lesion and surrounding structures, so similar to what we talked about in the last question. The other question that garnered a fairly high response, FNA, you do not want to FNA parathyroid carcinoma. It can seed the track of the FNA, and so if you have a suspicion of parathyroid carcinoma, you just want to take it out. A 62-year-old woman comes to the emergency department with altered mental status, myalgia, and oliguria. Her serum calcium level is 14.5 and her parathyroid hormone level is 300. What is the next best step in treatment? A, bisphosphonates to reduce further calcium absorption from the bones. B, IV fluid resuscitation. C, loop diuretics. D, sestamibi scan to localize abnormal parathyroid gland. E, ultrasound of the neck to look for parathyroid lesions. Question in the box, why not a central neck dissection for the last question? So again, if there's no obvious nodal disease, you don't need to do a neck dissection. Awesome, guys. Yeah, not much explanation needed. Fluid resuscitation. A 44-year-old woman presents with a small right thyroid nodule without cervical lymphadenopathy. Ultrasound shows an 8-millimeter cystic hyperechoic nodule with smooth margins. What is the next most appropriate step? A, observation. B, right lobectomy. C, total thyroidectomy. D, FNA.
A little discussion on this one.
All right, so the answer is A, but yeah, looks a little 50-50 there. So this is a description of a benign finding, right? It's cystic, it's hyperechoic, it's less than a centimeter. There's no mention of calcifications. So this can just be safely observed. If it were over 1 centimeter with concerning findings, things like macro or micro calcifications, or any other concerning for malignancy features, and it's 1 centimeter, then you do want to biopsy it. But anything under a centimeter, even with those features, gets observed. A 26-year-old man is found to have a 1.8 centimeter left thyroid nodule. Neck ultrasound shows no lymphadenopathy. FNA reveals a follicular lesion. What is the appropriate surgical management for this patient?
And if you could just share the answers as well, or read the answers.
Oh, I'm so sorry. A, total thyroidectomy. B, reassurance and no further intervention. C, total thyroidectomy with left central neck dissection. D, left thyroid lobectomy and or molecular marker testing. All right, D is correct. Left thyroid lobectomy and or molecular marker testing. Doesn't really seem like I need to go through too much on this one. You guys pretty much all got that right. A 55-year-old woman presents with extensive microcalcification spanning 2 quadrants of the breast on diagnostic mammogram. Stereotactic core needle biopsy demonstrates DCIS. What is the most appropriate treatment option for this patient? A, segmental mastectomy. B, segmental mastectomy followed by radiotherapy. C, unilateral mastectomy. D, unilateral mastectomy with sentinel lymph node biopsy. Or E, bilateral mastectomy. All right, most of you got this, but a little bit of debate. The answer is D, unilateral mastectomy with sentinel lymph node biopsy. So for DCI, you could do a segmental mastectomy, but in this question, it's spanning 2 quadrants of the breast. And so that's going to result in a really poor cosmetic outcome. So better for a mastectomy. And then you are doing that with the sentinel lymph node biopsy because there is a chance of DCIS being upgraded to invasive cancer on final pathology. And once you have removed all that breast tissue, you can't do the sentinel lymph node biopsy. So you do need to go ahead and do that if you're going to be doing the mastectomy.
All right. Dr. Rosenbluth, tremendous review of breast and endocrine critical topics for that site, of course, every year. And you handled the lengthy questions very well. So thank you.
Thank you.
And I'd like to transition to Dr. Sarah Hennessy, another great surgical educator and colleague from the University of Texas Southwestern. She's the director of the Surgical Intensive Care Unit and herself a minimally invasive general and bariatric surgeon. Dr. Hennessy will be leading us in the discussion of a variety of topics, including pediatrics, transplant, thoracic, and plastics. Welcome, Dr. Hennessy.
Thank you so much. And everybody be patient with me because it's a mixed bag of questions and I'm getting old and my eyes are getting old and my laptop's tiny. So I'm going to be leaning forward quite a bit. The first question, a 38-year-old male undergoes a split thickness skin grafting from a thigh donor site. Which of the following environments is most conducive to epithelialization of the donor site? A, dry dressing. B, wet to dry dressing. C, moist occlusive dressing. D, pressure dressing to prevent seroma formation. And then E, antibiotic application and wound left open to air. Okay, so the correct answer is C, moist occlusive dressing. And it looks like most people got it right, but I think worth kind of going over this. Remember the epithelialization occurs most rapidly under kind of moist conditions rather than dry conditions. And if you really want to promote a clean wound to heal well, you want to keep it moist with an occlusive dressing on it so that that exudate doesn't become infected. And that really optimizes epithelial migration. In addition to that, to expedite epithelialization under an occlusive dressing, it helps with pain control of the wound or the donor site. And the moist healing can be done with dressings, ointments, creams, or just continually moistening the dressing. The traditional wet to dry dressings, if you really let it dry, it really desiccates and causes necrosis of the surface of the wound. And so you're actually delaying epithelialization by doing that. So that's really only recommended if you're really trying to debride the wound because it is infected or it is necrotic on the surface. The next patient is a 43-year-old firefighter who has mixed second and third degree burns over 80% of his body surface area. 3 days after successful resuscitation, bilateral lower extremity escharotomies, you're contemplating excision and coverage of the lower legs. Which of the following is the best option? A, full thickness autograft, B, split thickness autograft, C, allograft, D, xenograft, or E, secondary intention. Okay, so a little bit of different responses here. The correct answer is C, allograft. We'll spend a minute on this one too. So ideally, an autograft is most ideal for skin closure. But remember, this patient has over 80% total body surface area burn. So the amount of viable skin to use for an autograft is going to be really limited. Because of that, the use of allograft is appropriate, and it'll allow time for the skin in less burned areas to heal so that eventually the patient will be able to get an autograft. Xenografts is not the correct answer because it is, although it's cheaper than an allograft, it doesn't really have the ability to vascularize or kind of heal in. And then secondary intention doesn't really provide good coverage and is not desirable. Okay, your next patient is an 80-year-old female who's bedbound nursing home resident with multiple comorbidities who's admitted for urosepsis. She has a tracheostomy for airway maintenance and a PEG for feeding. Which one of the following layers of her sacrum is most susceptible to pressure necrosis? A, the skin, B, subcutaneous fat, C, muscle, and last D, bone. Okay. So this is a good question to go over. The correct answer is C, muscle. So not skin, not subcutaneous fat, and go over here why that's the case. So the skin is the most resistant to pressure compared to the subcutaneous fat, which has much less blood supply. Or the muscle, which actually has really good blood supply, but is very sensitive to ischemia. And the bone is really resistant to pressure. So for this reason, often when you see sacral pressure ulcers, what you see is a skin that may not look too terrible, maybe like a small skin ulceration. But when you unroof it underlying, there's a large area of necrosis. And that prolonged pressure produces ischemia in the tissue by occluding the microcirculation. That's really how that necrosis occurs. This occurs when the tissue pressure exceeds the capillary filling pressure of 25 millimeters of mercury. Usually if somebody is on their back or on their sacrum for a prolonged period of time, that pressure can reach up to 80 millimeters of mercury. And so that's what really causes the necrosis. So maybe that's a good question to mark down for everybody. Your next patient is a 47-year-old man who receives a renal transplant for end-stage renal disease secondary to diabetes. He is counseled regarding the toxic effects of tacrolimus that he's taking. This medication may be associated with which of the following? A, pancytopenia and gastrointestinal bleeding. B, nephrotoxicity and neurotoxicity. C, thinning skin, easy bruising, poor wound healing, and changes in the appearance of body fat in the face, neck, back, and waist. D, thrombocytopenia and impaired wound healing. Or E, vomiting, seizures, and arrhythmias. Okay, great. So most everybody picked the right answer, which is B, nephrotoxicity and neurotoxicity. Again, that is the most common complication of tacrolimus. With pancytopenia and gastrointestinal bleeding, that's very common in mycophenolate toxicity. The C, thinning skin, easy bruising, poor wound healing, and changes in the body fat is most consistent with prednisone. And then lastly, vomiting, seizures, and arrhythmias, you see most commonly side effects of cyclosporin. An infant is 7 days post-exploratory laparotomy and bowel resection secondary to peritonitis due to meconium ileus obstruction. A sweat chloride test is positive. The infant has regained bowel function since operation. Which of the following is the most appropriate approach to starting feeds on this child? Breast milk with supplemental pancreatic enzyme replacement therapy. B, breast milk alone. C, standard formula alone. D, clear liquid diet. And then E, clear liquid diet with supplemental pancreatic enzyme replacement therapy. So a little bit of a shift into the peds world. Okay, great. Almost everybody got this right. Just really quickly, this infant has cystic fibrosis. Formula is not mandatory, and breast milk is definitely okay if the infant can tolerate it. Most infants with meconium ileus and cystic fibrosis in this situation are diagnosed with a positive sweat chloride test. And remember that these patients have pancreatic insufficiency, which is why they need that pancreatic enzyme replacement. If they have normal bowel transit, their bowel functions returned, then a clear liquid diet is really not necessary. Your next patient is a 12-year-old girl who presented to the emergency room after a 24-hour history of right lower quadrant abdominal pain and nausea. Your studies were suggestive of appendicitis. You take her to the operating room for a laparoscopic appendectomy. On entry, everything goes okay, but on direct visualization, the appendix actually does not appear grossly inflamed. What is the best choice for your next step in the management? So A, directly proceed with a laparoscopic appendectomy and await the pathology results to determine whether or not she'll require ongoing antibiotics for appendicitis. B, convert to open appendectomy to palpate the appendix and feel for an appendicolith. C, terminate the procedure, close the abdomen, and do a complete workup. D, carefully run the bowel, inspect the ovaries, pelvis to rule out another source for her symptoms. If no pathology is discovered, then remove the appendix and follow up on the final path. Or E, terminate the procedure without removing the appendix and treat the patient with a 7-day course of antibiotics for likely gastroenteritis.
Definitely a mouthful question. I didn't give them all to Dr. Rosenbluth.
Okay, great. So almost everybody picked the right answer, which is fantastic. Again, A, you do not need to treat simple appendicitis with antibiotics. And so that should not determine whether the pathology does not help you determine antibiotics, yes or no. In terms of converting to an open appendectomy to palpate the appendix, is very invasive for the patient. Really what you want to do is look at the entire abdomen, look at the ovaries, look at the terminal ileum for any terminal ileitis, look for a Meckel's diverticulum, and do your due diligence. And then if really everything is negative, it is perfectly reasonable to take out the appendix and wait for the final pathology, and that patient does not need antibiotics afterwards. Your next patient is a 14-year-old adolescent boy who presents in the middle of the night with a 2-day history of abdominal pain, nausea, vomiting, and fever of 38.5. His pulse rate is 95 beats per minute. His blood pressure is 80/55. Lab tests reveal a white count of 16, sodium of 136, a potassium of 3.2, a chloride of 93, bicarb of 32, BUN of 10, creatinine of 0.5. And imaging reveals a thickened appendix with surrounding inflammatory changes. There is also an appendicolith with a small amount of free fluid concerning for complicated appendicitis. What is the next step in definitive management? A, IV antibiotics with emergent laparoscopic appendectomy. B, IV antibiotics and CT-guided percutaneous drainage of the phlegmon. C, IV fluid resuscitation over the next several hours before proceeding to surgery. D, IV antibiotics followed by repeat CT scan in 4 days to visualize what should now be a well-formed drainable periappendiceal abscess. Or E, emergent appendectomy with copious irrigation of the abdomen and pelvis, followed by placement of a small drain through one of the port sites.
I need some discussion on this one.
Okay. Okay, so it looks like the two options that most people picked were A and C. The correct answer is C. And we'll talk a second about why A is not correct, although seems like maybe what's done in practice. So studies have shown that children who are operated on after overnight antibiotics and resuscitation actually have a much lower risk of postoperative abscess. And I'm not a pediatric surgeon, but from what I understand, there's a lot of changes and or controversies around taking care of appendicitis in children. Historically, it was thought to be a surgical emergency, that children with acute appendicitis required emergently to go to the operating room. But now we know that there is a benefit to a period of resuscitation and antibiotics before surgery. And so it's better to do the IV fluid resuscitation, get the antibiotics, and take the patient subsequent to that to the operating room, even if that is several hours later. In terms of repeating the CT scan in 4 days to visualize there being an abscess that's formed 4 days is not long enough in terms of formation of an abscess that is drainable. The imaging said that there was free fluid, so there is not a phlegmon to be drained, which is why B is not correct. And then with regards to extensive peritoneal lavage and suctioning during laparoscopic appendectomy for complicated appendicitis is no better than just suctioning everything out and not doing the copious irrigation. Your next patient is a 3-year-old Caucasian boy who presents with an 18-hour history of anorexia, irritability, and abdominal pain. His past medical history is notable for eczema and a recent upper respiratory infection. After workup in the emergency department, he's diagnosed with appendicitis. Which of the following factors most increases the likelihood of finding complicated appendicitis at the time of operation? A, age less than 4, B, recent upper respiratory infection, C, anorexia, D, Caucasian race, E, duration of symptoms less than 24 hours. As you guys have noticed a theme, there's a lot in the pediatric world on appendicitis on your exams. Okay, so a little bit of mixed responses here. The correct answer is A, age less than 4. And so the question's really asking what most increases the risk of that child coming in with complicated appendicitis. Remember, complicated appendicitis is defined as perforated or ruptured appendicitis. The answer is 4 because young children most commonly present late, and late presentations of appendicitis are more likely to be complicated. The other things that are associated with increased rates of complicated appendicitis is symptoms greater than 48 hours, Hispanic, African American, or Asian races, self-insured or public insurance, immunodeficiency, excuse me. Anorexia is frequently seen in patients with appendicitis, up to 75% of patients. And so it's a very common finding and not one that's necessarily associated with complicated appendicitis. A 7-year-old boy is status post a laparoscopic appendectomy for simple early appendicitis. After an uncomplicated postoperative course, he was discharged home on post-op day 1 without any additional antibiotics. He now presents in the emergency department on post-op day 5 with recurrent abdominal pain, diarrhea, and a temperature of 38. His mother reports that he'd been doing really well at home. He was tolerating a regular diet, having bowel movements for the first few days. What is the next best step in management? A, he should now be prescribed a 7-day course of PO antibiotics for his symptoms. B, supportive management only with IV fluids and bowel rest reassures family that he has an ileus, which will likely resolve soon. C, obtain a CT scan of abdomen and pelvis with IV PO and rectal contrast to assess for partial bowel obstruction at the ileocecal region. D, admit for a PICC line, IV antibiotics, NG tube decompression, and bowel rest until the diarrhea resolves. And then E, obtain an ultrasound to evaluate for a phlegmon, a drainable fluid collection, or an abscess. Great. E is the correct answer. I won't spend too much time on this other than to say that about 35% of pediatric patients present with complicated appendicitis, and about a quarter of those can go on to develop a post-op intra-abdominal abscess. Ultrasound imaging is always preferred to CT imaging for children in order to avoid radiation. And then all the other choices don't really get at making a diagnosis. Although he had initially simple early appendicitis, still at risk for postoperative abscess. So E is the correct answer. Okay, to shift gears to a totally different type of patient. This is a 60-year-old man who presents with a 6-centimeter mass in the right upper lobe, a non-small cell lung cancer that crosses the major fissure. There is no significant lymphadenopathy. His metastatic workup's negative. He has excellent cardiac and pulmonary function. What's the next step? Systemic chemotherapy, posterior lateral thoracotomy, video-assisted thoracoscopic surgery, muscle-sparing anterior thoracotomy, and then a hemiclamshell thoracotomy. I'm not as savvy as Dr. Rosa Bluth is to look at the Q&A and toggle.
I think we're getting most of them.
But she's a lot younger than I am, so I'm going to blame on that. Okay, so the correct answer here is B, posterior lateral thoracotomy. And the reason for that is that the patient is ready for surgery, doesn't have any lymphadenopathy, has good cardiopulmonary reserve, but it's a very large lung cancer. And due to that, that's why an open approach the patient may require a sleeve resection or a pneumonectomy, and that would allow for optimal exposure. And the size of the mass really precludes from a VATS approach. Okay, your next patient is an 80-year-old man, a former smoker. He's diagnosed with a stage 1A right lower lobe non-small cell lung cancer. He is referred to you for surgery. He says that he has mild shortness of breath after walking up a flight of stairs. He denies any chest pain or history of heart disease. His pulmonary function tests show a forced expiratory volume in 1 second of 1.1 liters and a diffusing capacity for carbon monoxide of 55%. What's the next step? A dobutamine stress echocardiogram, B, arterial blood gas, C, ventilation perfusion scan, D, cardiac catheterization, E, cardiopulmonary exercise testing.
Some discussion on this one.
Okay. So looks like A, C, and E were the most popular choices. E is the correct answer, cardiopulmonary exercise testing. In a patient with marginal pulmonary function, as determined by his FEV1 and DLCO, cardiopulmonary testing, exercise testing is predictive of postoperative complications and perioperative death. The maximal oxygen uptake, less than 10 milliliters per kilogram per minute, is prohibitive for surgery. If it's more than 15 milliliters per kilogram per minute with a forced expiratory volume in 1 second less than 40%, this is also predictive of poor outcome. So just really, determining whether or not this patient is going to tolerate this operation is what the question is getting at, less about, in terms of true cardiac disease with the cardiac catheterization and stress test. Your next patient is a 12-year-old boy who underwent successful small bowel transplantation 9 months ago. He has suffered no signs of rejection, has done really well, but just as recently presented with a fever and cervical lymphadenopathy. Abdominal imaging reveals numerous enlarged mesenteric lymph nodes. What is the most likely diagnosis?
You could read the answers, please, Dr.
Oh, I'm so sorry. I was so good up until that moment. I remembered every time. A, acute cellular rejection. B, post-transplant lymphoproliferative disorder or PTLD. C, cytomegalovirus infection. D, disseminated aspergillosis. E, herpes simplex virus infection. Sorry, that was a lot. Okay, perfect. So almost everybody got it correct. The correct answer is B, post-transplant lymphoproliferative disorder. The incidence of this is about 20% after small bowel transplantation, and it's associated with Epstein-Barr virus infection. The incidence is high because there's a large amount of lymphoid tissue that's transplanted in the small bowel mesentery. The patients are typically on pretty intensive immunosuppression, and that's what leads to it. It's often presents with symptoms very similar to an acute EBV infection: fever, malaise, sweat, cervical lymphadenopathy, and enlarged tonsils. They can have diffuse lymphadenopathy or disseminated organ involvement as well on presentation. Your next patient is a 58-year-old man, 8 weeks after undergoing a liver transplantation. He presents for just routine follow-up. His postoperative course has been uncomplicated. He has been maintained on tacrolimus, mycophenolate, and tapering prednisone regimen for his maintenance immunosuppression. In clinic, he complains of fatigue, low-grade fever, myalgias, which have been present for the last week. On laboratory evaluation, he is leukopenic, and he has a mild elevation in his transaminases. What is the most likely diagnosis? A, CMV infection. B, cryptococcal meningitis. C, intra-abdominal abscess. D, post-transplant lymphoproliferative disorder. Or E, acute cellular rejection. Okay, so the two answers that were picked most commonly were A and E. The correct answer is A, CMV infection. And a CMV infection is really presents typically as a viral syndrome with symptoms of fever, leukopenia, and myalgias, pretty vague. CMV can invade the tissues, causing hepatitis, colitis, appendicitis, retinitis, or pneumonitis. CMV infection may also affect the donor graft after transplantation. It can present very similar to acute rejection, so I can understand why people would have chosen that one, and can obviously become very serious, and people can be very ill. But in this situation, the answer we're looking for was CMV. Your next patient is a 45-year-old man who wants to donate a kidney to his brother. During the course of the evaluation, he is determined to be ABO blood group A. His brother is ABO blood group O. Which of the following is the best option? A, cancel the proposed transplant. B, proceed with the transplant without any additional intervention. C, enroll the donor and recipient in a kidney paired exchange program. D, proceed with the transplant after induction with thymoglobulin. Or E, proceed with the transplant after induction with a monoclonal antibody, basilizumab. Hopefully I said that correctly.
Mhm.
Okay, perfect. The correct answer here is C, enroll the donor and recipient in a kidney paired exchange program. So this donor and recipient are ABO incompatible, and due to that, rather than saying they can't get a transplant, there are kidney paired exchange programs, and they can find matches for people that are ABO incompatible to do as a swap. And so really that's the most ideal. And the other choices in terms of induction with immunosuppressants just really isn't appropriate and wouldn't help with the antibody-mediated rejection that is seen in ABO incompatibility. And then you would obviously hate to cancel an option of transplantation. And obviously, if you proceed with transplant, it's not going to go very well. So.
Dr. Hennessy, thank you so much for that excellent review. I learned a lot myself.
As did I. Thank you.
And for our final panelist this evening, I'd like to welcome Dr. Katapel, which is one of the smartest folks I know and one of the most skilled vascular surgeons I know. Dr. Katapel is from Washington University in St. Louis and is going to be leading us in the discussion of vascular surgery. Welcome, Dr.
Thank you, Dr. Awad. So a 65-year-old male with stage 4 CKD presents to you for vascular access, and vein mapping shows a 4 millimeter cephalic vein and a 3 millimeter brachial artery with good flow. A decision is made to create the left brachiocephalic AV fistula instead of using a non-autogenous graft. Why is fistula a good choice in this patient? A fistula provides better flow rates for dialysis. B, graft has an unacceptably high infection rate. C, primary unassisted patency for a fistula is higher. And D, cumulative patency rate is better for a fistula. And E, a fistula can be accessed for dialysis sooner. All right, so most of you got this option right. So cumulative patency rate for a fistula is better, but some of you guys answered C, that primary unassisted patency of a fistula is higher. That's actually not true. So most stage 4 CKD patients show up for dialysis access, and we create fistulas first, more so because it's better for them long-term, because the patency rate for fistulas long-term is better than grafts. However, upfront, a graft normally is ready for use within a few days for early stage grafts or within a month for routine grafts. And on the other hand, fistulas oftentimes require other interventions like balloon-assisted maturation, coil embolization of side branches, or ligation. So overall, fistulas take a lot of effort upfront to make them work, but they tend to work a lot longer. So that is why we prefer fistulas. The flow rates are almost identical, and grafts do have a higher infection rate, but it's not so substantially higher that it's prohibitive. Next question, 2 months after placement of a brachiocephalic AV fistula, a 67-year-old female presents to you with pain in her hand below the fistula that worsens during dialysis. She's already on low flow rates during dialysis, and that cannot be lowered any further. On exam, she has a cool hand with only a radial signal. When you compress the fistula, the hand becomes warm and the radial pulse becomes palpable. Angiography shows that the fistula is patent without any inflow or outflow obstruction, so you've ruled out any arterial issues. Next best management choice is A, reassurance and reduction of dialysis flow, B, brachial bypass with distal brachial ligation, C, distal revascularization and interval ligation, also known as drill, D, banding of the fistula and narrowing of the anastomosis, E, ligation of the fistula. All right, so mixed bag response. So the scenario describes a patient who has arterial steal syndrome from the fistula, which happens not infrequently. So you cannot just say that we'll just watch and see what happens because she's complaining of a lot of hand pain and her flows are already low during dialysis. So that is obviously not the right option here, because if you do nothing, potentially it can turn into a gangrene and tissue loss. Brachial bypass with distal brachial ligation is not a very specific answer, because that's, even though it's very close to option C, which is drill, it does not really describe the technique by itself, because distal revascularization and interval ligation is a specific technique that requires you to do a proximal anastomosis further up, at least 5 to 10 centimeters higher than where the arteriovenous anastomosis is coming off. So option B is not very specific, so that's the wrong answer. We'll come to C in a second. Ligation of the fistula can be one of the options, but that is not obviously the first answer that you think of when you're talking to a patient who needs a dialysis access long-term. So it's between C and D when you come to this question. Banding can lead to fistula narrowing to the point where you lose the access completely. And especially when you're trying to save a fistula, you try to do the best you can. And in those scenarios, drill tends to work really well. If we go to the next screen, we have visual representation of a few different things that are oftentimes used to help patients with ischemia. Banding is one of them. So what you do is you narrow the proximal main body of the AV fistula to the point that the flow through the fistula is adequate. And at the same time, you have to evaluate and make sure that their digital perfusion pressure is better. This requires a lot of coordination and can be done successfully, but it works only in centers where they have ability to monitor fistula flow volumes and at the same time figure out what the digital pressures look like with a lot of AV fistula thrombosis rates. Drill is a very standard and accepted modality to address this, where you restore arterial blood flow distal to the arteriovenous anastomosis site by creating a bypass from the brachial artery proximally to the brachial artery or an ulnar artery distally. The key important feature is that the proximal anastomosis has to be 5 to 10 centimeters higher than the arteriovenous anastomosis, and you have to divide the brachial artery just distal to where the AV anastomosis is. The other options are you can either proximalize the arterial inflow by taking a graft from the axillary artery and running that into the fistula and then ligating the AV anastomosis. Or another one that is commonly being used these days is taking the arterial inflow from a distal artery, like for example, a radial artery, and hooking that up to the fistula so that majority of the blood flow to the hand is restored through the dominant artery, like the ulnar artery. 65-year-old man is undergoing placement of a subcutaneous port for chemo to treat metastatic esophageal cancer. He receives conscious sedation and local anesthetic. Because the patient is right-handed, left subclavian site is chosen. His BMI is normal. Despite 3 attempts, including an arterial puncture on the final attempt, cannulation of the vein is unsuccessful. As the right side is being prepped, the patient's oxygen saturation falls and he develops tachycardia. What is the most likely cause for these new symptoms? A, oversedation, B, air embolism, C, pneumothorax, D, thoracic duct injury, and E, mediastinal hematoma. So most of you got this question correct. So pneumothorax is one of the most common complications from a line, especially a subclavian line. And option B is air embolism. Likelihood of that happening is low because you're just using a micropuncture needle to access, and you were not able to cannulate the vessel. Next question. 53-year-old female with a 7-centimeter tumor of the right breast is diagnosed with inflammatory breast cancer. She's advised to undergo neoadjuvant therapy with chemo prior to resection. You've been asked to place a subclavian tunnel catheter with subcutaneous reservoir for chemo. So essentially, you're being asked to place a port. You are discussing risks and benefits with her. Which of the following risks is lower in a port compared to a triple lumen catheter in the same position? A, venous stasis. B, catheter-related venous thrombosis. C, catheter-related bloodstream infection. D, pneumothorax. And E, arterial cannulation. So most of you got this question correct too. It's bloodstream infection. So anytime you have either a port that's subcutaneous or you have a catheter that is cuffed and tunneled, the odds of having an infection and introducing an infection to this through the skin site is minimal. So which is why we prefer to place ports or tunnel catheters in case of dialysis access long-term, rather than just leaving a triple lumen or a quad lumen catheter behind. So the other odds of venous stasis, device-related thrombosis are almost identical, whether that be a triple lumen or a tunneled catheter or a subcutaneous port. A 65-year-old woman who has an AICD in the right subclavian position is in the ICU after an MVC with left clavicular fracture with extensive bruising. She needs central venous access, and you decide to place a right IJ catheter under ultrasound guidance. The best reason to use ultrasound guidance in placing the central venous access is A, to reduce catheter-related bloodstream infection regardless of the site. B, to reduce pneumothorax from a subclavian catheter. C, to reduce all complications from IJ catheters. D, to properly situate catheter tips after all lines. And E, to reduce the number of placement attempts. So oftentimes when you run across such questions, it's not so much as to which all options are correct, but you're trying to almost read the examiner's mind and try to pick the best out of the bunch. So my advice to everyone who's taking these tests is to take off your clinical hat and put on your exam taking hat on and try to read through questions and come up with the best solution to the problem. So a lot of you answered E, to reduce number of placement attempts. While that is true, option C is more appropriate, because not only would you reduce any complications related to IJ catheters with ultrasound, you can optimally choose the site of where you would access the internal jugular vein. Your chances of hematoma, your chances of pneumothorax would be reduced because you can watch your needle tip going into the vein appropriately. Your odds of arterial cannulation would be lower. And yes, it would reduce your placement attempts, but that is also part of the complications of placing these catheters. So option C would include all of these other things that we talked about, rather than just E, which talks about only one particular problem. 67-year-old man underwent coronary stenting after an MI a day ago. He is found to have a pulsatile groin mass at the site of arterial axis. What is the best test to confirm the diagnosis and plan therapy? A, MRI, B, ankle brachial index, C, arterial duplex, D, CT angiogram, E, bedside Doppler. So the correct answer is C. So whenever we come across any pulsatile mass after an intervention, we're thinking of a pseudoaneurysm. So most pseudoaneurysms these days are treated with conservative measures if they measure less than 2 centimeters in size, or they're referred to interventional radiology or vascular surgery for thrombin injection, which is widely accepted as a suitable treatment modality. Arterial duplex helps with that because it helps you understand the neck of the pseudoaneurysm, which kind of plays a role into whether these pseudos can be injected with thrombin or not. We do CT angiography in circumstances where we find that the arterial duplex shows a pseudo that is either not suitable for an injection or does not need intervention. So those other modalities come in play, like CTA or MRA, when you do not find suitable anatomy on an arterial duplex. But one, duplex is a non-invasive way to diagnose these pseudoaneurysms. It does not require contrast. It's non-invasive. So I think that is the first line of modality when it comes to pseudos for both diagnosis and treating and planning treatment. A 55-year-old male underwent a partial colectomy for diverticulitis. On post-operative 1, he's found to be unresponsive and is intubated. After multiple attempts, a right femoral vein catheter is placed. A large hematoma at the site is seen the following day without skin necrosis. Distal pulses are still palpable. Color flow duplex ultrasound shows a 1.6 centimeter pseudoaneurysm. What is the next step in management? A, observation and repeat ultrasound in 4 weeks. B, resection of the pseudoaneurysm and interposition graft. C, endovascular covered stent. D, ultrasound guided thrombin injection. And E, ultrasound guided compression. I think we kind of touched upon this question in the last explanation. All right, again.
Discussion on this one, yeah.
Yep, so like we talked about in the last scenario, right? So you encounter a patient who has a pseudoaneurysm. The first step in how you diagnose them is with an arterial duplex, which they performed. And it showed a small pseudoaneurysm. It measured less than 2 centimeters. It was only a 1.6 centimeter pseudoaneurysm. Most pseudoaneurysms less than 2 centimeters in size spontaneously thrombose within a couple of weeks. So they can be safely watched, provided there is no evidence of skin necrosis or expansion during observation. This patient is still in the ICU. So if they were to have any expansion, you would obviously have to figure out a different plan here. However, based on the scenario that is provided where there's a large hematoma, but there is no evidence of skin necrosis, and actually the ultrasound showed a very small pseudoaneurysm, odds are that this will thrombose on its own and would not warrant any treatment. If it were to warrant some treatment, then you would again repeat the ultrasound duplex and possibly use ultrasound guided thrombin injection as the first modality and reserve primary repair of the pseudoaneurysm in case that fails. C and B are oftentimes used, but again, it's not the first line in management for these small pseudoaneurysms. A 49-year-old woman with diabetes presents with a large erythematous first toe with purulence. She has no palpable pulses and pedal signals are faint. Her ankle pressures are not obtainable due to incompressible vessels. What is the most appropriate management? So essentially, it's a 49-year-old diabetic with toe gangrene, with some pus, with PVD. Option A, open first toe amputation and antibiotic therapy, followed by revasc. B, first toe debridement, followed by TMA a week later. C, FEMPOP bypass with PTFE and 6 weeks of antibiotics. D, ankle disarticulation, followed by BKA 3 days later. And E, lower extremity balloon angioplasty and stenting, followed by toe amputation 2 days later. What is the downside of using ultrasound compression at the time of diagnosis? Ultrasound compression, you can order it, but most places do not routinely do it, unless, I'm not sure if you have experience with that in your hospital, but if I order an ultrasound compression, I don't think I can find a vascular tech to go by bedside and compress a pseudo for 30 to 45 minutes. I don't think there's anything wrong with it. It's just not needed for those small pseudoaneurysms. So most of you got this option correct. So this patient has a diabetic foot infection. The first and foremost treatment modality in this particular circumstance is control of sepsis. So you do an open toe amputation for the infected toe and start antibiotic therapy. And on the back end, you revascularize them and figure out a definitive therapy for them. Doing option E, which would be lower extremity balloon angioplasty and stent placement, is probably not the right answer because the patient had cellulitis and had purulence coming out of the toe. So that needed to be addressed before you could revasc them. So a 58-year-old man was successfully treated for claudication with a right FEMPOP bypass 3 years ago. Over the past 6 months, he has noted a return of his right calf pain with walking. He has continued to smoke a pack a day, and he has recently been diagnosed with type 2 diabetes. A duplex shows no flow in the right leg bypass graft. What is the most likely cause of his bypass graft failure? A, acute thrombosis from hypercoagulability. B, peripheral thromboembolism. C, progressive atherosclerotic disease. D, intimal hyperplasia of the distal anastomosis. And E, diabetic small vessel arteriopathy. Do we still need antibiotic therapy after toe amp? It depends on the circumstance. If they have a lot of cellulitis, oftentimes patients are maintained on antibiotic therapy until revascularization is done. But if they have an isolated gangrene with just a focal infection, once you get rid of the infection, you treat them with 24 hours of antibiotics. All right, so whenever patients have bypasses and they fail immediately within a month or within a day or within 2 days, something like that. So in the first month, if a bypass fails, it's one of two reasons. One, it is a technical failure, right? You did not do something right and it failed right away post-op. Or it could be lack of outflow. You chose poorly, whether it was the inflow choice or the outflow choice. Between 6 months and about 18 months, patients tend to have intimal hyperplasia in certain select patients, in about 10% of patients, where they have this intense hyperplastic response where the body tries to heal itself and deposits a ton of tissue, especially at the anastomosis sites, thereby shutting down these anastomosis or these bypasses. That typically happens within the first year and a half. Beyond 1.5 year to 2 year mark, when people lose their bypasses, it is oftentimes related to atherosclerosis. Now, this fact about intimal hyperplasia being that starts right away as soon as you touch the vessel, but is most prominent clinically between 6 and 18 months, and atherosclerosis being the primary cause of problems down the road over 1.5 to 2 years out, is true for any vascular bed, whether that be a carotid, whether that be a bypass, or anything really in the vascular space. So that is a fact that you need to know. A 60-year-old man has severe right thigh cramping after walking 100 feet. His right ABI is 0.8, and a CT angiogram shows severe focal stenosis of right common iliac artery. What is the most reasonable treatment strategy? Number one, aorta right iliac artery bypass with PTFE. B, medical treatment with aspirin. So essentially, you just take aspirin. C, fem bypass with right greater saphenous vein. D, right iliac artery balloon angioplasty and stent placement. And E, smoking cessation with repeat angiogram in 6 months. So essentially a very short distance claudicant with severe right common iliac artery stenosis. I think most of you got this correct. So if one of the options read trial of graduated exercise regimen with antiplatelet therapy and smoking cessation, I would have argued that would be the first step. However, between the choices that have been presented, doing an aorta right iliac artery bypass with PTFE as the first line treatment is probably not the right answer. It's quite invasive with a lot of risk. Option number B, nobody picked it because, it was inadequate. Option C, a few respondents picked fem bypass. For a 60-year-old, a fem bypass would not be the right answer, even under normal circumstances when you're considering bypasses in general. In addition to that, you generally never do fem bypass with a saphenous vein because it does not have good patency. You instead use something that is reinforced with external rings like an 8mm PTFE graft. Smoking cessation is important, but the patient is quite symptomatic and can walk only 100 feet. The option does not mention any of the other medical modalities. Option D is iliac stenting. For a common iliac artery, an iliac stent would have upwards of 80% patency at 3-year mark and upwards of 90-some% patency with the current technology of stents at 1-year mark. So it is a widely accepted, very safe intervention to give patients with claudication significant relief. So for claudicants, doing interventions for inflow disease, I think it's fairly acceptable. When you go down below the inguinal ligament, I think you have to be more judicious with your interventions. Someone has SFA stenosis, how do you decide on what to do? Well, you choose medical management with graduated exercise regimen first. It depends on your practice, but you tend to not intervene early for these patients until they show you that they really are limited in terms of their daily activities. And if that's the case, if it's a long occlusion and they have a suitable vein for a bypass, you pick a bypass. Otherwise, you pick an endovascular intervention. 70-year-old woman is transferred with a 1-month history of bilateral forefoot ulcer and pain at rest. She had an MI 6 weeks ago and has EF of 30%. MRA of aorta shows complete aortic occlusion distal to renal arteries with reconstitution of both common femoral arteries. What is the most reasonable treatment strategy? A, axillobifem bypass with 8mm PTFE, B, aorta bifem with 16/8 bifurcated Dacron graft, C, aortic endarterectomy and patch angioplasty, D, primary bilateral above knee amputation, and E, heparinization and delayed aorta bifem in 6 months. So essentially, sick lady with heart failure, recent MI, with infrarenal aortic occlusion and rest pain with ulcers. So critical limb-threatening ischemia.
bit of discussion on this one, I think.
Or maybe oh yes. So like we were talking about this patient, she is an older lady with congestive heart failure with recent MI, so she's sick, and the level of occlusion for her is just below the renal arteries. So traditionally, in somebody younger and healthier, the treatment strategy for this patient would be a bifurcated aortobiafemoral bypass. But with her EF of 30% at her age with recent MI, she's not going to be able to tolerate that. So we can cross off option B as one of the options. Option C similarly would be a very big intervention for a patient like this. Besides, aortic endarterectomy is oftentimes reserved for focal lesions, perhaps at the distal end of the aorta, close to the aortoiliac segment, where you can do bovine patch angioplasty to treat essentially bad iliac stenosis, right? And that is one of the options. Again, not a very commonly used option, but it can be used. Again, a huge surgery, she's not going to tolerate that. Option D would not be acceptable, right? Because you're just saying, since you have rest pain and minor tissue loss, we should just do above knee amputations, which would also not be great. Besides, you also have poor inflow at this point in time to heal even an AKA, so you can't even guarantee that. Option E, you just heparinize and do a delayed aortobiafemoral bypass with an EF of 30%. Odds of her improving over 6 months is reasonable from a heart standpoint, but her legs may not, survive the next 6 months. So you need a strategy. An extra anatomic bypass is oftentimes an expeditious way to address infrainguinal revascularization and aortic occlusion patients who are sicker and not candidates for big aortic interventions. Bypass with EF 30%. Yes. Most vascular patients are actually pretty sick, so 30% is not unusual for some of these older patients to offer them a chance at limb preservation. A 72-year-old man is admitted to the ward with dyspnea or topnia and paroxysmal nocturnal dyspnea. He's noted to have pitting edema in his bilateral lower extremities. His right leg feels larger than the left. He denies chest pain or pleurisy. He has not used compression stockings in the past. How will you proceed with investigation? A, bilateral lower extremity venous duplex. B, echocardiogram. C, CT, angio of chest. D, captopril challenge. E, photoplethysmography. So some of you mentioned bilateral lower extremity venous duplex. So this patient is coming with classic heart failure symptoms. They have dyspnea, they have orthopnea, they have proximal nocturnal dyspnea. This is like the classic description of acute and chronic or acute heart failure. So their pitting edema is likely secondary to heart failure rather than just a primary lower extremity pathology. I think the confusing part in the stem is that the right leg feels larger than the left, but the rest of the symptoms all point towards a primary cardiac pathology rather than a primary leg pathology. So B would be the correct option. You would not pick A for this because the rest of the stem does not point towards a primary leg problem in this case. 36-year-old woman presents to your office with bilateral lower extremity edema. The overlying skin is not tense and is non-erythematous. Symmetrical distribution of fat is located between the hips and the ankles. The feet are not involved. You can pinch the skin easily and lift it at the base of the second toe. What is your management plan? A, weight loss. B, leg elevation. C, venous ablation. D, lymphatic bypass, or E, compression stocking. So essentially, it's more of a question of diagnosis than treatment because you have to figure out what the diagnosis is here before you figure out the second part of the equation, which is management. So the answer is A. A lot of you answered E, compression stockings. That would not help in this scenario. So they're describing a patient who has lipedema. So the three differential diagnoses in this case would be lipedema, lymphedema, and some sort of venous insufficiency, right? So they're describing the patient as having symmetrical distribution of fat between the hips and the ankles. So lipedema affects the lower extremities, especially more so in women than in men. It can also affect arms. The line that cinches the diagnosis is that the feet are not involved. So in lipedema, the feet and hands are never involved. The second thing that differentiates it from lymphedema, which would be the close second, which could be confused with this directly, would be what happens in the foot. One, the foot was not involved in lipedema. And number two, you can pinch the skin easily off the base of the second toe, which in lymphedema, you cannot, right? You have square toes and you cannot pinch the skin. The last differential diagnosis would be some sort of a venous disease where you would have pitting edema, and which was also not described here. So weight loss, oftentimes these patients are obese. This is not a primary obesity related problem, but weight loss can help to some degree in these cases. So weight loss would be the right answer. Compression stockings do not help with lipedema. Oftentimes you have to refer these patients to a plastic surgeon for liposuction and manual lymphatic drainage of sorts, but leg elevation, venous ablation, and lymphatic bypasses would not work because those are primarily targeted towards lymphedema and venous insufficiency. 64-year-old female presents to your office for evaluation of a swollen left lower extremity extending from the inguinal ligament distally. She underwent an isolated left lower extremity limb perfusion for a history of malignant melanoma. She denies pain but endorses night sweats. What is your most likely diagnosis and imaging study? A, May-Turner syndrome with iliac vein evaluated with iliac vein duplex. B, lymphedema tarda evaluated with CT angiogram. C, pelvic adenopathy, CT abdomen pelvis. D, greater saphenous vein reflux with venous duplex. E, Stewart-Treves syndrome and lymphoscintigraphy. So a patient with malignant melanoma who presents with leg swelling. So half of you got this right. Again, it was kind of a hard choice between some of the options. So a patient with malignant melanoma, one of the common causes would be recurrence and lymphatic mets, which can present in a delayed fashion that can cause lymphatic congestion and cause swelling in the extremity. That would be the first thing you would think of when a patient has had a history of malignant melanoma. That would be best evaluated by CT because you would be able to see a bunch of cluster of lymph nodes in the pelvis. A, May-Turner syndrome with iliac venous duplex. It is possible, but it is less likely. The first thought when you think of cancer is cancer. So while DVT is possible in these circumstances, that would not be your first thought. Lymphedema tarda is primary lymphedema in older adults, like 35-year plus. Again, nothing in the stem kind of points towards lymphedema tarda, so this is an unlikely choice that I would pick. The greater saphenous vein reflux Again, she has extensive swelling going all the way from the inguinal ligament going down. So it has to be something more proximal than the inguinal ligament. And GSV reflux is unlikely to lead to that. Stewart-Treef syndrome is primary lymphangiosarcoma. It would not present this way and in this age group. So the right answer is pelvic adenopathy, which should be the first thought when you're dealing with somebody with malignant melanoma, to rule out lymph nodes first and think of DVT next.
All right, and that was our last question for the evening. I want to thank Dr. Kedapal for a phenomenal review of vascular, and also like to welcome back all of our panelists as well. That was a tour de force, but a wonderful review of some key important topics that will undoubtedly be seen on the app site in a couple of weeks. To our panelists, again, thank you for your expertise. You really impressed me, and again, I learned a lot, and we thank you for committing your time to teaching us all this evening. For those of you in the audience, I also want to thank you for joining us tonight and being a part of our annual SAGES General Surgery Review. This is an annual tradition that we do out of real dedication to our trainees throughout the country and throughout the world. And we really appreciate you taking time out of your busy schedules to be with us this evening. Also want to just remind folks about what a amazing meeting SAGES is, and I would hope that you'd be able to join us in Montreal in a couple months' time. Again, these are one of my favorite meetings to attend each year for the scientific content, the professional development, and the ability to see great friends and colleagues, and hope to meet and see many of you at this meeting shortly. We do send a poll out to our webinar participants, and I hope that you'll take just a few seconds to complete the poll to let us know how we did. We read your comments very carefully, and we try to make adjustments every year based on your feedback. So please do take a few seconds to complete that poll. And finally, for those that are taking the app site, I want to wish you good luck in a couple of weeks as that's coming up. Again, this whole webinar will be posted online at the sages.org website. Look for it in just a few days. With that in mind, thank you all, everybody. Have a good night. Take care and be well.